at the Department of Postgraduate Dentistry in PRMU, that stands for Perlovsky Research Medical University in very nice city, Nizhny Novgorod in Russia. So it's a very brief introduction, but I know that you are very more than what I have introduced you. So please, Dr. Teterin, start your presentation.
Okay, thank you. Let's start. First of all, I want to thank you for your invitation to do this webinar. It's a great pleasure for me to see you again. Second, I am so sorry for my English. Of course, it's not my native language. My native is Russian, but I try. Yes, but I try. Okay, let's start. Sorry, how can I share my presentation? You see one slide.
You see the first slide?
Yes, but I can't check. One moment. Sorry.
Okay. No, take your time.
One moment.
It's okay. Take your time.
I can't list my.
میس صادقی خانم صادقی باید چی کار کنن تا بتونن فول اسکرینش بکنن اسلایدا رو؟
خانم دکتر اسلایدا فول اسکرین هست. من دارم فول اسکرین میبینم اسلایدا رو.
ولی ما الان فکر کنم فول اسکرین
نه
شد.
الان استاپ شیرینگ کردم. الان استاپ شیرینگه. بذارین مجدد شیر کنم.
باشه.
One moment, please. Sorry for this technical. Oh, yes, it's okay.
Yeah, it's okay.
Yes, sorry. I'm from Nizhny Novgorod. It's a great, beautiful city. It's geographically, it's European part of Russia. It's about 1 million population. So I like my native town, yes. And my work is in Privolzhsky Research Medical University. I am associate professor at the Department of Postgraduate Students, of postgraduate dentistry. So I work not with students, but with doctors. We have good training center. It was excursion to our training center. Yes.
Yeah.
Yes.
We saw. Yes, we saw.
Yes. Do you see video? Yes, it's good.
Yeah.
Okay,
yes,
thank you.
Yes, we can see the video.
Yes. Why I show you this? Because I want to show that my work is practically oriented. I'm not a theoretical teacher, but my job is to train the dentists. I want to start from my opinion about the paradox of the current situation in dentistry. So I don't know how it's in Iran, but in Russia there are some, I think, problems in dentistry. First problem, I think, it's increase of massive invasive clinical cases. So when patients come to our dental practice, we try to do maximum of our variety. So we try to do ortho, prosthetics, perio, and so on. But I think as a doctor, yes, I think that sometimes it's not so good. It's hyper treatment, you know, and our responsibility is not to do much dentistry. Our responsibility is to do good health for our patient. So sometimes it's not so good in Russia. The second paradox is that we have very good, very beautiful aesthetics, but very rigid materials in our practice. You know, common complication for prosthetics is chipping. Yes, and engineers and factories try to do rigid materials. But what about patient? What about his TMG? What about muscles? What about adaptation? So the third problem that I think in prosthetics, in dentistry, is that we have new data on human dental variability. We are all different. We are all different. You, I, we are different. But in special literature, the ideal bite is one, and it's not so good. We try to treat our patient on the one common rules, but we are all different. And I think that treatment must be individual. We have to understand individual parameters of the patient. So it's I think it's problem in common dentistry in Russia. And I think that the fifth problem, yes, that our dental system of a modern person, its adaptive capabilities is decreased due to constant stress. It's political, economical, information. We live in stress, and our patient live in stress. So adaptation of our patient is decreased, and we have to meet with different not so good complications because adaptation is not so good. So these problems I see in my practice, in practice of my colleagues, practice of doctors that come to our university. And besides the amount of patients that come to our practice with the different complex cases is very there are a lot of patients with such not so good cases at the start. We see surgical problems, perio, ortho problems. But in spite of this, our patients want to look like that, you know? They want to have a beautiful smile. They want to have white teeth. They want to get result fast. They want to get this result not so expensive. So, but at the start, sometimes we see like this, and it's a problem. Yes, and that's why I tried to do something with my protocols to solve these problems. And at what point I come? It's integration of digital instruments in my practice. Yes, and I can say that dentistry now is in transformation. It's in the process of integration of digital technologies to our treatment, clinical process of dental treatment. So the first concept before we start to discuss jaw motion analyzer, but I want to start with the beginning, with the data collecting. Yes, and in my practice, when a patient come with difficult, complex case, first of all, I do a digital data collection. Yes, I do digital clone of digital copy of patient. Well, it's scans, photo, video. We do face scan, CBCT, and axiography or myography if it needs. Yes, so we can do every patient with complex cases. We do this the virtual page, the virtual copy of the patient. We can with this clone, with this digital clone, we can do better communication for multidisciplinary planning with our colleagues. Yes, we can see it's asynchronous. It's a problem when we start to discuss with the surgeon, with the orthodontist, and sometimes it's not so easy to meet at the same time, because I work, my patients, surgeon, his patients, it's not enough time. So, but when we do this digital data collection of the patient, when we do a digital clone, it's easier. It's easier. Second time, we can do testing and modeling the treatment process. We do it on the laptop. So, for example, when we do implant surgery, we do the operation first time in virtual. So it's a guided surgery. We can put implants, so we can model our rehabilitation before we do rehabilitation. Yes, it's very good. And the third benefit, I think, with this concept, that we do our treatment, most of procedures, medical procedures, out of mouth. So you understand that dentistry is not so good. It's not spa. Yes, it's not comfort for patient and for doctor, of course. So some of medical manipulations we can do out of mouth. So and when we collect the data, yes, at the start of the complex case, we pay attention on the 4 diagnostic parameters. Yes, you understand it's function, aesthetics, structure, biological. Yes, it's common rule. Every dentist know it. And what is interesting, traditionally, we pay attention first on the function, biology, structure, and design is on the backyard. Yes, but I changed my practice, and I think it's a modern thinking, that the starting point is to do design. It's to do some project before we start to do any medical invasive procedures in the patient. So it's like before the building, the house. First of all, the architect is working. Yes. Then and he do design. Then engineer, and only after that builder. Yes. So in dentistry we can do like this. We do design, then we can do treatment plan, and only after that we begin to do our procedures in the mouth. So I show you one small case. We start from design. You can see one guy with not so pretty smile. You see that there is some problems with tooth, yes, gum, and not so good. Okay, I understand that this the patient of orthodontist, of course. But before we start do irreversible procedures, I want to test and model. I want to model the treatment process. And so what we do, we do you hear? It's okay, yes? We do 3D modeling, yes? And after the first appointment, after the first visit, we do data collecting. And in my practice, I model with the software his new smile. Only design. Function is second, yes, but the starting point is design. And we use acrylic to do a mock-up. You know what is mock-up, of course. It's not problem to do mock-up. It's very simple. But look, we can see how change the smile. Yes, and between first appointment and second appointment, it's about 2 or 3 days. It's not invasive. We do mock-up on his teeth, yes, and it's good. We can show the patient the result. We test this, and we can see for ourselves, for me, for prosthodontics, for ortho, how it will be look, and this is a finish point. Yes, we have to go to. So it's a process. We do it in ExoCAD. It's no problem. Yes, we do this model, and look, we do. His teeth is not so good. Yes, and our modeling is rather up from his starting. Yes, and when we do this acrylic in the mouth. You see, his native teeth, we can see it, yes, but it's no problem. We do markers, yes, and in mouth black, yes, and when we do photo and video, it's okay. It's okay. So when we was in Nizhny Novgorod, I'll show such cases, yes, but I think it's not problem for do good aesthetics and good mock-up. It's not problem. Yes, 3D printer, good acrylic. It's acrylic. Yes, not problem. It looks like natural. It looks like natural. It's not ceramic. It's only mock-up. But what about aesthetics and function integration? What the problem? Yes, and I can show you one case. Yes, it's part of big rehabilitation. We do ceramic veneers. It was in 2016. It was good, yes. We do it, but I from about 5 years passed, and my patient come to my practice with this chipping. Yes, it's a problem. Okay, why this problem? Maybe dental technician is not so good, or maybe patient chewing spoon, for example. Yes, I don't know. I don't know. Yes, but first, yes, that you do your work good. It's a dental technician or the patient. Yes, of course, but not you. Yes, it's psychology. But I show you a second case. Yes, we change one crown on the incisor. It's first picture, it's crown. Then we do surgery. We try to change gum. Yes, because it's not the same. Yes, and we do one new crown. Yes, more aesthetics. Yes, but a year passed and we see this problem. Yes, so why we speak about aesthetics for what if it not work? Yes, where aesthetics without function, it's not good. It's not medicine. Yes, it's about like to do makeup. So this patient with central incisor, you can see that see her lower incisor. When she speak, her lower incisor put on the upper. Yes, you see it. But as a matter of fact, her bite is like orthodontic. But when she begin to speak, lower incisor come and bite. So what the problem? The problem that sometimes when we do some veneers, some aesthetic rehabilitations, yes, and we want to improve the aesthetics, we do our restorations, but when the position of the incisal edge interferes with the movement of the lower jaw, it can be functional or structural problems. And so how can we guess, how can we fix this problem? Yes, besides, it's data from the article of Weinberg and Kruger. It's a classical article that when we change the angle of the incisors, yes, for aesthetics, for example, yes, but every changes of 10 degrees, but the loading is increased. So that's why, and why we do it, aesthetics. You know, a lot of patient with such problems comes to our practice. People want to do good, beautiful, attractive teeth. Yes, but in fact, I see that in Russia it's a great amount of patients with increased tooth wear, a great amount. I think it's the reason of it. The reasons of it. It's a longer life expectancy. Yes, acidic diet and a stressful life. So that's why patient come to practice. They see that their teeth are increased, and they say to the dentist, I want my teeth to be more visible, to be more bright." Yes, and we have to do a new smile with teeth with too big than the starting point. Yes, too big. But we can but we understand that when initial vertical dimensional occlusion, it's initial bite. Yes, and if we do more long the incisors. Yes, overbite is increased at its increased load, and then we meet with complications, with chipping, yes, with great load to the perio of these teeth. And of course it's not good. So how we solve this problem? Yes, we increase vertical dimension of occlusion. Yes, and it's a classical article that the increasing of the vertical dimension of occlusion is safety and predictable procedure. Yes, by 5 millimeters, we can do it. Yes. It's good, and we can see that patient, yes, third lower third of face after the increasing. Yes, I show protocol how we solve it. Yes, and it looks pretty, it's look good. You see, it's okay. Yes, when we increase vertical dimension of a lower third of face. It's we call bite lift. It's like facelift, plastic surgery is facelift, but it's bite lift, and it's okay. It's anti-age dentistry. But yes, and one more good thing, that when we see initial vertical dimension of occlusion and we need a space for restoration, yes, we have to prep our teeth. But when we increase, we can prep in an enamel, and it's so good. We can get the space, yes, for the restoration material. Yes, how can we do the increasing of vertical dimension? We can do it in articulator. Yes, in chisel pin, and it's okay. But there is one problem. When we do it in articulator, it's common, it's simple, but look how the trajectory of the mandible, it's standard, it's in pattern, it's not individual, and the palatal surface of the incisor is bigger. Yes, it's not good for phonetics, for example. And if we see, and when I use jaw motion analyzer for my patient, it's I understand that every person is individual, and there is a variability of the mandible trajectories during mouth open. Yes, when we do it's an articulator, it's standard, but patient different. So I understand that these parameters, functional parameters, is necessary to understand before we start invasive procedures, and it's in digital, and we can do it on laptop. So let's see. Jaw motion biomechanics of the mandible occur around the TMG. It's one more problem. Patient with the TMG disorders. And I think, and there is theory, yes, that there is correlation between teeth and TMG. Yes, I think every prosthodontist understands it. Yes, there is correlation. But how can we find this correlation in the patient? So we know, yes, there is a theory that between joint and incisor there is correlation. What we can find a sagittal joint path. So when patient do protrusion or open mouth, there is a trajectory that joint path, and there is angle, and it's individual. And they say that sagittal incisive path, they will be more steeper. So when we look at our patients, and there is classification of angle, yes, first class, second class it is distal, and third class is mesial. And you'll see, if you do jaw motion analyzer, you'll see, yes, that the sagittal joint path is different. A patient with first class it's about 40 degrees, yes. If a patient with second class is distal, yes, when distal, this joint path is about more than 40 degrees. It's 60 degrees, yes. So, and mesial third class, there was about 20 degrees. It's a standard. And I understand that when these three persons come to my practice to do prosthetics, I understand that biomechanics of dental system of each depends on the type of facial skeleton. And I want to know the protocol, how to do my restoration safety, because this restoration will different on first class, second class, third class. They will be different. So it's like so mandible movements. It's like a finger. It's individual, and that's how can I solve this problem? Yes, and I use our jaw motion analyzer. Yes, and we record the comfortable individual trajectory movements of the lower jaw and TMG. So a little video how we do it in our clinics. Later I explain I explain every part of it. So it's a digital face bow. This digital face bow. We then we take scan with this face bow. These markers that we with composite, with adhesive, fixed to the mandible, to the maxilla, and this optical camera, and we do some tests. You'll see, and this camera fix these markers, and in such case we record the mandibular movement. So what the set of this jaw tracker? First, it's an optical jaw tracker. It's an optical camera. Then we put to the head. We put to the head. It's very easy, and it's have USB and put to the laptop. On the laptop there is a special software. I'll show you later. It's a first optical jaw tracker. It's the first part of this system, of this set. Second, it's a wireless digital phase bow. You know what is phase bow, yes? In analog, we transfer the position of the maxilla to the articulator. But how can we do it in digital? And we do it with this gadget. Yes, we put it on the mouth. Yes, it's the same. But there is a little gadget, yes, with one button. Patient come to the, we need to understand natural head position. So besides mirror, yes, patient with this device, and I'm doctor, put the button, and the data come to the laptop, to the software wireless. It's very easy. And track markers is the third part of it. Yes, we fix it on the mandible and maxilla. It's very easy. Yes, I take flowable composite, and there is simple rules. We have to fix it on canines. Yes, maxilla it's to the left and the mandible to the right. Yes, fix like curing, and we start to do our recording, and to to do it more simple for you, I prepare videos in English. Yes, and I show you. Yes, it's the creator of this system, and you can fix this link. In Russia, this system calls ProSystem. In Russia, it's in Russian, of course. But international website is SDI Matrix. When we come to this site, you'll see that it's in Switzerland, in Zurich, but it's Russian. Yes, Dr. Evgeny Roshin, it's the developer and creator of this SDI Matrix system. Yes. So I want to show you a little some videos. Yes, how we do it. Yes, it will be in English. It's better English than I can do. So the patient come to the dentist. Yes, and this digital phase bow. Yes. To use it with virtual articulation. I show you later how it works. Yes, we fix it with silicone like classic phase bow, and yes, it's natural head position. Before mirror, yes, and pick. These additional markers, yes, it's light curing. It's very simple to use. I think in my practice it's about 30 minutes for one axiography. And ProAxis, it's an optical camera that we put on the head.
Do you put anything inside the TNJs?
No. It's enough. It's enough. Yes. So later you understand why face bow with markers with this. Yes, and we ask patient to do different movements. Yes, I show you the protocol of the creator of the system. So, and this camera fix, yes, and translate it to the laptop, and it's recording. It's recording. Yes, we can put CBCT to the software. I'll show you. It's very, very useful. It's very useful. Yes. So, next video, it's in English. Yes, I prepare.
Thank you.
Is it good for you to look these videos? You hear? Yes, yes, it's
Yeah.
okay. Yes.
Yeah,
Thank you.
very okay.
Thank you.
Thank you.
So,
Axiography, movement
hear?
registration, minimum axiography required list for analyzing. First of all, we need to record mouth opening and closing, protrusion, left and right laterotrusion.
It's
We
a
call
protocol.
it habitual movements or stereotype movements. What does it mean? We do this type of axiography firstly, we do not give patient any advices and do not rehearse how to move. It must be comfortable to patient. Automatically you understand how these movements are complicated. For example, look at open and close movement. You can analyze it, check centration of lower jaw, the first contact or deviation, also analyze right and left joint, difference in amplitude, and also analyze forward movement, protrusion, left and right movements. You don't give any advices to patient because you need to understand comfortable way to move the jaw. How stereotypically movement formed, abrasion and teeth decay. Also check the treatment. So, this stereotypical axiography very informative, because you see how patient close his mouth and return back in habitual bite, how he open mouth, deviations, so it's all record by axiography. The second axiography is movements with tooth guidance. Here you record protrusion and laterotrusion, supported by teeth. It's necessary to analyze guidance teeth, presence of any super contacts in molars area, how lower jaw moves forward and returns back. Laterotrusion movements. It's necessary to analyze working side, here it is a right movement. We check teeth involved in canine guidance. But we also analyze contacts on balancing side. Maybe we have a super contact there. It's very important because all super contacts and dynamic occlusal disorders force trajectories and can be the reason of TMJ disorder. That's why we analyze working side and balancing side. With such trajectory, protrusion and laterotrusion with tooth guidance, it is comfortable to estimate harmony of digital parameters. We can compare sagittal angle of articular guidance and sagittal angle of incisal guidance, Bennett angle and canine guidance. Wrong positioned teeth, destructed teeth make lower jaw to move on forced trajectories. The second type of axiography, it's like a simplified digital analysis. Third record. It's also protrusion, left and right laterotrusion, but it is a movement free of tooth contacts. This is necessary to evaluate clear joint movements, and also get articulator settings. This movement gives us possibility to estimate joint movements when teeth don't influence direction. Check changes of trajectory, because tooth guidance very often change trajectories. This leads to differences in tooth and joint trajectories. The third record shows smoother trajectories. It's like one of the criteria of differential diagnostic, how teeth guide trajectories and how trajectories become forced. These are 3 necessary trajectories which you need to record. After that you can add in articular analysis any type of trajectories like abruxing, speech and chewing. That this list with 3 axiography is obligatory to record. All trajectories record together to evaluate how trajectories of opening, protrusion and laterotrusion are similar in the initial stage or it's have some differences, and it's all necessary for functional analysis.
I try to explain, yes. So when patient come to my practice, and it's a complex case, we decided to do big prosthodontics or orthodontics, for example, yes. What data we have to analyze about jaw motion, yes. We record first of all free or stereotype movements without touching teeth. So it's a comfort for patient, yes. We don't explain what to do for patient. We put the camera, markers, and we say open, close mouth, stereotype, comfort, and patient open, close, protrusion, and left lateral protrusion. Then it's important, we do these movements, but supported by teeth. So we analyze, we compare we're dentists, and we want to know how these existing teeth influence on the dental system in whole. So we have to record movements supported by teeth. It's a second axiography. And third axiography, when we want to do protrusion, left-right lateral protrusion, without supported by teeth, only clear movement in TMG. Teeth is not guidance in this moment. We see how the TMG movements clear without any guidance, yes? And we compare these 3 axiography, and we compare it with the situation in the mouth. We see the position of tooth, maybe erosion, maybe chipping, something, yes? And we find the correlation between this clinical situation, yes, and the dental system as the whole. How the dental system, I mean, TMG, muscles, works, and it affect it will affect on the restoration, big restoration, expensive restoration, yes, for our patient, yes, how it will affect. So that's why we use this gadget. So let's continue. Yes, when we do axiography, after that we put the CBCT in this software. Yes, and I want you to see how it works. So we do our digital protocol and we check it. Yes, a little video in English, little video.
Digital protocol checking. We have two ways how to check digital protocol. First way, you can check complex diagnostic, which include individual models and axiography. For this you need to select section, individual models, on the right menu. Models should be aligned previously and added to complex diagnostic. Find the section, show contacts, and tick, select top view.
It's very important to see contacts and this color indication, you see?
Then in the left bottom menu in axiography, set select first axio and using a slider on a scrolling bar move the track at the beginning, in habitual occlusion.
And we can
Then
analyze
we analyze initial point and check occlusion. We shouldn't see big number of red zones. The red zone is an intersection. If you see them, this testifies to wrong determined habitual occlusion during axiography, or individual models were with wrong bite. So they were uploaded in program with intersections. We should do the same with every recording. Highlight every diagnostic and check the initial occlusion. Here all diagnostics are correct. The second way of checking quality of digital protocol is to unite CBCT with individual models and axio set.
So we can see the correlation between teeth and TMG. It's the system.
We make slices of TMJ on both sides and check the condyle trajectories. They shouldn't cross the eminence. Check it on right and left sides. This is a recorded trajectory and this is the eminence. Do it with each axiography and check intersection of bone structure. This diagnostic was recorded correctly.
And when we analyze the movements, we can see the movements in TMG. What the good. Very useful in my practice, when to our office come patients with TMG disorders. Yes, it's clicking, pain, it's not good, not so perfect bite. Yes, and this software, and we do splints, of course, occlusal splints. Yes, but how can we do it effective? I think traditionally we do it in articulate. Yes, but in digital. So in digital, we have such instrument called digital variator. And I want you to show the possibility when we do axiography and we have CBCT, how we can change the position of mandible to treat TMG. A little video.
Digital variator. For work with digital variator, you need to make the complex diagnostic, which includes axiography set, individual models, traced CBCT. Everything in this complex diagnostic should be aligned. Lower jaw should be detached. For selecting digital variator, on the top of the right menu find Digital Variator and click it. You can find values in table for incisal point, right joint point and left joint points. Choosing the icon, Move, you can use the arrows. Moving of the lower jaw will display in the table for each point. If we want to move the lower jaw down, we can use the arrow, or change the value in the table. If we want to use table for this, you need to place mouse pointer to the need zone and scroll it in positive or negative way. If you scroll in negative side, the value change, lower jaw will go down. If you scroll in positive side, the value change and the lower jaw rises up. All values in the table are in millimeters. The next icon is Rotate Around Joints. If you click on it, arrows will change to circle and you will be able to rotate the mandible around joints. The same time values for incisal point also will change. You can also rotate around left joint and rotate around right joint separately if you select the next icons. Rotation around left joint will display arrows and give you opportunity to move it up, down, right and left. And the same thing for the left joint. Also, Digital Variator can use current lower jaw position as an initial. It will change position of the mandible from habitual position to target position. To reset the values in Digital Variator, use the right icon, Reset. To switch off the manipulator for Digital Variator, use the left icon, No Action. And then you can hide the section of Digital Variator.
So what the benefit? I try to explain. A patient with TMG disorder, and this disorder is the reason of this disorder is problem with bite, and we understand that we have to change this bite. How can we test it? We do a splint, occlusal splint. And how can we do this splint? Traditionally, we do it in articulator, yes, existing bite, and we change it, yes, maybe distraction, maybe anterior, something lateral, we change it. But when we do it on articulator, we can see the changing of position of TMG. We can see, we cannot control. We only see the changing between models, position of models, yes? But in when we use digital, we can use instruments, so Digital Variator, and we change maybe distraction, yes, new position, and we think that it will be good for this patient. We can vertical, and before we do splint, we see what changes in TMG. It's very useful for dentists. And nowadays, I do occlusal splints under the visual control with axiography. Yes. So when we change, we do new position of mandible. What we do after that? After that, we export these scans to the dental technician software, and they export in this position, new position. And I want you to show how it looks. Yes, in Russia we use Exocad. It's the most popular software of dental technician in dental laboratories. So this axiography, this tracker is integrated with Exocad. I'll show you a little video how it works. We export from software our scans with new position, and look, this virtual articulator, not analog, not traditional, but virtual on the laptop, and we can load a little file that export with scans, and look, and new position, yes, and it's easier for dental technician to do occlusal splint. When we do great prosthetics, not every time we use this trajectory, but every time we program virtual articulator, not standard angles, but individual angles. And how we do axiography, analyze what angle of disocclusion of this patient when patient do protrusion. And do protrusion, we record it, and we see what the clear angle of the joint, left and right. Yes, we see, and then we program virtual articulator with this data, and it's individual articulator, not standard, individual. So the I think that there is a Ganau quint, this classical theory about correlation between functional parameters. It's a condylar guidance, incisal guidance, occlusal plane, compensation curves, it's Speer or Wilson, and cuspal inclination, cuspal of molars, of premolars, and so on. So these 5 parameters correlate between. So we are dentists. How we can affect to the incisal guidance? We can model incisal guidance more steep or not. We can affect on it. We are dentists. Occlusal plane, no problem. We can change it with our prosthetics, with ortho treatment. Yes, we can affect on it. Compensation curves, the same. Cuspal inclination, our dental technician can do cuspal inclination steeper or not, but how we can affect on the condylar guidance? No, because condylar guidance, remember, it's like fingerprint. It's individual, and we can't affect of it. It's anatomatic. It's morphologically it's anatomy. It's individual parameter. Condylar guidance. So, what the strategy? The strategy is to understand to fix individual parameter of condylar guidance of patient, and then it affects on the incisal guidance. For example, when we understand condylar guidance, it's maybe like second class. So we understand that incisal guidance, we have to do the same. But if third class, it's more steeper. And when protrusion, yes, it's maybe not so, but so. And I understand that incisal guidance, the same. What will be if condylar guidance is vertical? It's individual parameter, it's anatomy of patient. Yes, it's his skeletal parameter. And it's vertical. And we don't know it. We don't know it because we don't analyze axiography. But we do our veneers or crowns, and the dental technician do it, but without any parameters. And maybe it's will be done like this. Condylar guidance, vertical, and its body horizontal. Or maybe we want to do good aesthetics and do big long teeth, vertical, yes, but but morphology of the TMG of the muscles of patient is horizontal, and there is conflict, and there is problem. So it's Ganau Quint. Ganau was from Holland, and he was engineer. No, he create articulator Ganau. But I think it's very useful for practice, for dental practice, yes, to know these parameters, to know this correlation, and I think I integrate in my practice. It's really so. It's really so. And I understand before treatment, I can explain my dental technician why we need to do more steep, more vertical, or more horizontal incisal guidance, occlusal plane. It may be more horizontal or more vertical, and so on. And we do it not blind, we do it visible, and we can understand. And if we, of course, we have, of course, some problems, yes, at the stage of diagnostics. But when we, but when these parameters is visible, it's easier to understand. It's easier to understand for me. And so I can say this, that when this Joe Draker appear in my practice is changed, of course. It's changed. It's not so difficult to test it. Yes, it's very friendly for everyday practice. It's the most difficult not to do axiography. The most difficult is to analyze it in software. It's not so, maybe it's not, this software is rather difficult because a lot of parameters, buttons. So, but in time, yes, you have experience. You do it not every day in my practice, but every week. Yes, I think every week, and you can, and you begin to understand the this program. Yes, and so this device I can advise to, of course, clinical to clinic. Yes, when we do big rehabilitations, a lot of ceramic crowns, veneers, when we change bite. Yes, when we want to get good aesthetics and function, we use it before orthodontics, because changing bite, and of course it affects on TMG, and you know, one of the complications after orthodontic treatment is TMG disorders. I think that one of the problem of this, that we have in our mind one pattern of ideal bite. It's first class. But what we can do with patient with second class, yes, second skeletal class, we change teeth, they become first class. Yes, it's pretty good, but muscles and TMG is in second class. We can change it. So I think that it's not good to treat different people on one rule. It's not so good, and that's why we do axiography, and we understand the class of patient not only by cephalometric, but with jaw motion. Yes, and I can advise to do axiography to better understanding biomechanics of mandible at all, because in Russia, in our dental schools, it's very poor information. It's not so interesting. Yes, protrusion, lateral protrusion, Bennett, and so on. Gothic angle. Yes, it's not so interesting. But when you start to do axiography, 10 people, and you see the differences, you see that the open mouth, it's not difficult, yes, but the trajectory is so different, so variable, yes, and so when you want to increase vertical dimension of occlusion when you do prosthetics, yes, after that, never, you'll do it only by increasing incisal pin of articulator on the. No, it's not work. It's a standard, and it's not work because you'll see that the human being is so interesting, and the dental system of each person is so interesting. You know, I see. I record showing. Um, and some people showing vertical, and I'll see that they have high cuspal high, and some people showing horizontal, and I see wear of abrasion of teeth, and I understand that this patient come to my practice to do beautiful new teeth, yes, white teeth, good aesthetics, and so on, yes, and we have a pattern, yes, to do to all the patient good anatomy of the molar, yes, scaspal, fissures, yes, it's beauty on photo, but how it works in the patient that have horizontal movements. It's his natural movements, yes. And we do high hospital because it's cool, because it's like patient at the age of 50, and we do tooth our prosthetics him like he's 20. No, it can be problem, and it depends only on adaptation of his dental system. Maybe it adapts to this new form. Yes. And it depends not, and you do, oh yes, I'm good dentist, I do good case, but it depends not only on your qualities. No, it depends only on adaptation of this dental system. So when I do this axiography, for me it's like book. It's like book, and I understand biomechanics. Yes, because I see that horizontal, vertical join or mix, and so on. So it's I think that when we start our diagnostics, yes, our dental technician understand that the first step that we do is design. Yes, and it's not problem to do good mock-up. We do only aesthetic surface, only vestibular surface. We want to see how it will be look, but how it will work, it's a functional surface, and this more important, I think. It's more important, and so we understand the trajectory of TMG, of muscles, of protrusion, lateral, and so here we integrate aesthetics and function, and form follows function. Yes. So I tried to show you by videos, little videos, by my not so good English, a small report. I tried to do a small report. Yes, how it works. It's a tracker, a jaw tracker set, how it works, how it looks. So I think that my presentation is finished, and I'm glad, with pleasure, I answer your questions.
Thank you so much, Dr. Teterin. It was very interesting, and I enjoyed it like that. The last time I see you. Now, I have a question from our audiences, and then I ask my own questions. Let me ask have this question. What is the influence of macro tracker thickness on the accuracy of digital bite registration in severe occlusal discrepancies or during bite correction procedures? Do you want to again? I ask.
You can send this question, and
it's
I
in
show
the chat box.
Huh?
Can you see the chat box? It is in the chat box.
Okay.
What of the questions are in the chat box?
I tried to, yes, chat, yes. Hello, hi, good morning. English caption for the program is activated. Yeah, I saw some there. What is the influence of macro tracker thickness on the accuracy of digital bite registration? In severe occlusion discrepancy or during bite correlation? I think that it's a good question. What the accuracy of the digital bite registration? Yes. The influence of the scanner. The influence, not axiography. There is a protocol when we record the movements, but then in software we do we combine these tracks. It's only tracks on with digital models. With digital models, yeah, it's not so. It's very easy. It's very easy, and the accuracy of digital pipes depends not on axiography. It depends on accuracy of the intraoral scanner. In my experience, it's rather accuracy. It's rather accuracy. In my practice, it's prime scan. Prime scan, it's Sirona, and it's rather good. Yes, I think for me, for my requirements, it's okay. It's okay. So the thickness, yes, accuracy of digital byte depends on intraoral scanner. If you don't use intraoral scanner, you do impressions, traditional, conventional impressions. Then you do cast, yes, is Gibbs cast, and you have to scan it in laboratory scanner, and the accuracy depends on the accuracy of scanning in laboratory scanner, and it's okay, it's no problem. And then you import these scans to the software, and it's okay. What factors most influence the accuracy? I read second question. Yes.
Yeah. And then he has asked, how can we have this software, as we asked you in the Nizhny? Is it somehow we can buy it with discount, please?
The software?
Yeah, or device, actually.
It's not impossible, I understand. I can send you the program. Yes, it's exe file. But this software we can put in, switch on this by the license, and license of the set of axiography. So each set have license, and you can't use it without axiography, unfortunately. So I can send you this, and you can download it from the SDI matrix.com. There is a download button, and there is their files. But the system is protected by ID, by license. So you can't use it. We have two sets, two axiographies, two jaw trackers, two sets, and on one computer, on my laptop, program and license from one from the first jaw tracker, and it not works with the second jaw tracker. I have to change license, and so it begin to work. So that's the politic of the creator.
Yeah, that's it. Yeah.
Yes.
We will talk about it later. Now,
Yes.
I have a question. So with this axiography, you do actually mock-up in the virtually with all the adjustments of the articulator, with the use of this axiography. And so, do you have any articulator in the software to adjust it, to give this scores to it? What is your articulator?
Yes, it's a good question. We have three types of articulators. It depends on your own experience. So it's Aman-Girboch, articulator SIM is the second, and cover. But I use Aman-Girboch. I can say that 90% of my daily practice, it's Austrian system Aman-Girboch. We have it in physical, real Aman-Girboch, yes, and virtual. Now, in our clinic, we have a digital laboratory. It's if you want to do digital dentistry, you have to work with digital laboratory. And what does it mean? It means that dental technicians that works in this laboratory, they have to understand the principles and protocols of digital. Because there is a problem in Russia. Traditionally, of course, it's conventional, analog, traditional dentistry without digital impressions, casts, and so on. It's handmade restoration. But in our clinics, it's computer aided, and it's in digital, not only clinical stage, but dental technician stage. And I can say that I don't use traditional face bowl, don't use. We have it, we use it earlier, yes, but now we use digital, this digital face bowl, because it's easier. The second, when dental technician, we send scans, it's a cloud. Dental technician on his laptop, he receive scans, and he receives the data of the jaw movement of the patient. And dental technician know how to program virtual articulator. It's not so problem, yes, but we have to do some seminars with dental technician to explain how it works. Because if dental technician don't know what is it, sagittal condylar guidance, what is it? No matter 20 degrees, 30 degrees, yes, he don't know what is it, because he work in standard articulator, yes. So it's very important to that you have to explain to your team, to dental technicians, how to program. So that's why we use Aman-Girboch physically. We continue use it in digital, and sometimes we use SIM, but it's not so fun. It's not so fun.
So, Dr. Teterin, is it necessary to transport the data from axiography to any articulator, or is it necessary, or it is not?
I think it's necessary. When we understand the individual parameters of the TMG and everything is acute about TMG, yes, it's very its affects very effects on the dental system. Yes, very strong. So in our clinic, it's a rule that when we change bite, when we do our prosthetics in existing bite, it's not so important, I think, because it's existing bite. We don't change it. And I think it's the best way to do it, and the same when we do one crown or maybe one bridge, yes, and existing bite, okay. But when we change bite, I do axiography 100% every time, yes, and I want to compare existing bite, yes, the bite that patient come to our practice at the start. I analyze the position of TMG. I understand sometimes we do myography. It's a gadget to understand how works muscles. And I combine this data and analyze. And so I think that when we change bite, we have to do axiography and use these individual parameters. So what?
So for the for a full mouth rehabilitation, I think if we want to go digitally, we should have a face scan, oral scan, CBCT, and axiography.
Yes.
And then we can do mock-up inside the software, and of course, wax up in the software, and then transfer it to the patient's mouth. And
Yes.
so, with the help of the axiography, we can have the all the data that we conventionally give to the articulator. With the axiography, we will have it inside the software, and we know the all the different angles we adjust it in the articulator.
Exactly. Yes.
Again,
Yes.
Again, we have in the chat box something. One, how can we get the software? I asked it, and then they have thank you for your nice presentation. And
Thank you.
last one, the last one is, can you tell us about the accuracy of this jaw motion analyzer system in Bennett movement and Bennett angle calculation?
No, I can show you in time, but I can express my own opinion. How we can Bennett movements with the lateral occlusion, yes, and the optical system works in such way. On the markers, there are points that fix, that optical camera fix, and when the markers move, the accuracy of the movement depends on the one moment, just one moment. Depends on the distance between the camera and markers. So the system control this distance. And there are green light, yellow light, and red light. And when you put these markers to the mouth, to the teeth, if system show you the distance is okay, this marker is green light, it's okay. And if you do axiography with exact distance, it's very simple, I think. The calculations of the angle is very correct, very correct. It's I think you can you use this data when you program articulator, lateral occlusion, and you see that lateral right and lateral left difference. Yes, it's maybe 10 degrees and 12 degrees. So it's very correct, I think. If you do correct protocol of data collection, yes, but program is help you. Program is help you to control it.
And you say that since when you have used this program, axiography, you think that your works are better and better results you have in the long time. You said that at the beginning.
It's very good. It's very good question. You know, when I come to seminar or conference, when maestro shows their cases, their presentations, you know, it's wow. But for me is more interesting. It's the complications of this maestro. Yes, it's not so difficult to do showcases. Yes, in Russia we call it showcase. Oh, look, it's initial, it's prep, it's impression, it's final, and so on. But what will be after 2 years, 3 years, 5 years? Yes, it's the salt. It's the most important thing. And I will be honest. Of course, I have different complication in my practice. It's not the instrument that that you have, that your practice will it's okay. No. But this instrument helped me to analyze and to make decisions more visible. So I do temporary crowns, temporary veneers to test new bite, for example. And my patient come to my practice after 1 week, and I see that there is some chipping, or maybe I see that loading to the right side and loading to the left side is differences. Loading to the canines is difference, maybe. And I analyze it, and when at the starting I have the data about the starting bite, about the starting movements, I can check and fix it more carefully, more simple, more comfortable. So I think that this device do for me
Very helpful to do
Yes,
for my
yes, yes, yes.
communication at least.
It helped me one hand. It's okay. Yes, yes, it's very helpful. Yes,
From
it's very
all of
helpful.
our audiences, I thank you a lot again, and for your
Thank you.
kindness and your time that you and all the information you shared with us. Thank you. I can't thank you enough because you're accepting my invitation, and we hope we see you again here, at least in Iran. So we are about 15 minutes over our time. I have
Oh,
to say goodbye and thank you so much for everything.
thank you. Thank you for invitation. Sorry for my English,
No, your
but
English is very
I
good.
tried. Thank you, thank you. So have a good day.
So I hope we can get this gadget, as you say, or device, of course, with the help of,
Yes,
with your help or your PRMU help, that will be very good.
yes, yes, yes. It's very good. I think
Yeah,
it's very good. It's very useful.
yeah.
Yes.
Thank you so much. Have
Thank
a good
you. Bye. Thank
bye.
you.
Dr. Rai said bye bye too.
Bye. Bye. Thank you.
Bye. خیلی ممنون از همه کسایی که تو این جلسه شرکت کردن.